Hi there, my name's Danielle Rankley, a program coordinator with the Upper Midwest Telehealth Resource Center. Thank you for attending this session of the Upper Midwest Telehealth Resource Center's Telehealth Bootcamp series. This series is being presented in collaboration with the University of Mississippi Medical Center's Center for Telehealth and the Ohio State Office of Rural Health. We're excited to be able to provide you with access to this incredible series, previously closed to the 2026 Telehealth Bootcamp applicants only. If you have more questions about telehealth or want to know more about the Upper Midwest Telehealth Resource Center, please come visit us on our website at umtrc.org. You can peruse our library of resources, check out our blog and podcast, and contact us to receive up to 10 hours of free telehealth technical assistance per year. Thank you again for joining us. Let's get started.
Okay, yes. So thank you all for joining for our second webinar. We hope that you did get something out of the first one, and hopefully you were able to look over the empathy exercise and do some of that. I did a little bit of it myself. And just we maybe get some thoughts on what that experience was like for you. I know that it's a little different because, of course, we are providing some direct content about telehealth and healthcare and all of that. But we intentionally wanted to include some things that bring back the human aspect of what we do. It is very tempting in the telehealth world to focus on the technology and the workflows, but we definitely need to remember the people, why we do what we do, and what kind of frames our thoughts and our approaches to providing healthcare. So I'm going to apologize in advance for Sean Nason. He messaged me and said that his internet is out. So he's working on seeing if he will be able to get on. But thankfully, it was my turn to present. So y'all are stuck with me today. But the goals of the presentation today are, we know that we will not be able to tell you everything there is to know about remote patient monitoring, advanced primary care, or CCM, chronic care management today. But this is to give you just a little bit of a foundation and to be able to compare them today. Remember, as a part of this cohort or of this program, we want you to be thinking about your respective organizations and which of these models, or it may be a combination of these models, might work for your clinic, your hospital system, whatever. That's going to help us, even at the end, if you have not actually implemented anything, it's going to help us to narrow down ways that the TRCs, the Telehealth Resource Centers, or the COEs may be able to help you, to implement those things. So it kind of gives you some structure as you go along. So we want you to pay attention and absorb all of it. But at the end of the day, we know that you won't be thinking about, we're going to do all three of these, right away. But we need to start somewhere. So that is the purpose of the presentation today. I'm going to go ahead and share my screen. And as people enter in, I may pause and just kind of update them on kind of a change in our plan for today, if Sean, in fact, is not able to join. All right, so do y'all see the first slide in my slideshow?
Yes, looks great.
I'll make sure that you all can see it. All right, so we're talking about here scaling chronic disease management through telehealth models. I mentioned already that the models that I'm going to share about today are the remote patient monitoring, otherwise known as RPM, CCM, which is chronic care management, and then the advanced primary care model, APCM. Y'all know who I am, so I don't think I need to do that. All right, so we want to articulate the role of telehealth in chronic disease management. We hope that you leave here knowing the difference between the three models and that you have some idea of what type of staffing it will take to implement these things. Think about which models work best in various settings, and then assess your own organization's readiness. This is that last thing is something that, it can make or break you. Because, everybody wants to do everything. You want to do it quickly, but we do need to say, are we ready, to do this? Why do we need new models? So why do we come up with these things? Those of us who've been in this world a long time, and I know not this world meaning telehealth, meaning the healthcare provider world. I know Mary can relate to this, dealing with people in Mississippi. Mostly everybody has some type of chronic disease, and we are more reactive, and we're reactive to what the patient presents with in clinic. But something that we have to address is, how do we support patients outside of the clinic setting? What are we doing in between visits to support them and to help them? It makes our job much easier and their experience better, or helps them to improve when we can support them in between visits. So chronic disease requires continuous, not episodic care. So that's what I just said in a nutshell. Most deterioration occurs within visits. For those of us who are providers or nurses of any kind, how many times have you seen a patient, you gave them a great plan, they're out of the clinic, and you expected them to come in for their follow-up visit doing better, and they were actually doing worse, and you had no idea. Or there were some things that you could have done to prevent them deteriorating, but you didn't know about it. Workforce shortages are accelerating, so we've got to do more. Value-based care rewards longitudinal management. So value-based care means you've got to do a good job of taking care of this patient with diabetes, not just you got to see them, bill for a visit, and we're going to pay you. And then telehealth extends beyond the clinic walls. That's one of the beauties of what we do, is it is not reliant upon the patient showing up into our clinic. So here are the three models. Remote patient monitoring focuses on physiologic monitoring using connected devices. So this is what I'm talking about today when I'm talking about remote patient monitoring. Chronic care management is structured non-face-to-face care coordination. And we all know chronic care management is not new. That's been going on, for quite some time, with nurses calling patients, or, health providers calling patients. Check-ins is kind of what, I call them. And this is just the name that they have given it. And then advanced primary care management is comprehensive population level primary care management. So it's like what I would do for my patients that are being seen at my clinic. And I would choose population. So I may say I'm going to do advanced primary care for all of my patients with diabetes that see me in my clinic. And I'm going to set up a system for how I will comprehensively care for them. So no more am I just doing my little piece of assessing, diagnosing and writing a prescription. I'm concerned about whether or not they're able to get their prescription. I'm concerned, about whether or not they are following up with that specialist that I referred them to. Closed loop referrals is a big part of this. So keeping up with all of that. All right. And then model selection should match your organizational readiness. All right. And we'll talk a little bit about how you assess that. I know all of you may know what remote patient monitoring do. Some of us know what it is, and some of us think we know what it is. So I always like to make sure that I provide some baseline information or definitions, descriptions of what these things are before we go any further. All right, so remote patient monitoring uses connected devices to collect physiologic data at home. Common conditions are, of course, hypertension, diabetes, CHF, COPD. It supports early intervention and proactive care and requires structured clinical protocols and monitoring. So I am going to emphasize that third bullet, actually, which supports early intervention and proactive care. I want to share some stories as we go about some different instances where, some things were done very well, and also where some things were not so well. So we have been doing remote patient monitoring here at the medical center since the study started in 2013, 2014. And I would say probably in 2019, 20, somewhere in there, we started getting lots of requests from other organizations who either they received some funding, and it was tied to remote patient monitoring, or maybe even to hypertension management or something like that. And they wanted insight from us on, what could they do? Okay. One of I will say, a pitfall that occurred that we recognized in one of the groups was they had received funding and they went out and bought equipment. So that was the first thing they did, was they went and bought all these blood pressure cuffs and issued them to their patients. And the patients were using them. And in the conversation, I asked the question, so who is receiving that information and what is being done? And the room went blank. Okay. So they were saying that they had a remote patient monitoring program because they were dispersing equipment. Their patients had it. The patients were taking the blood pressures, but they honestly just had a whole database full of blood pressures. Nothing was being done. There was no clinical team behind the monitoring. That is not a true or an effective model for remote patient monitoring. It's designed for you to get this information so that you can do something with it in a more proactive manner. The last thing is also very important. One of the things that we are very particular about when providing remote patient monitoring services to other sites or to other groups is that there is a structured clinical protocols and monitoring. And some of our members of our team will be sharing with you at the on-site event what those look like and what they produce. The reason why is not because we just want out of control, but it is kind of that we want control, but it's mostly because we want to make sure that we standardize the response, to the data that is coming in. We all know that all providers have their way of doing things. This is one of those cases where it's not good for all the providers to be following different protocols or, ordering this type of blood pressure medicine just kind of on a whim. There has to be a process in order for us to ensure that the patients will get results that are on par with what we found in our research studies that led to our live remote patient monitoring program. So it's important, just like we all have standards of practice, all disease states have kind of a textbook plan for how we should treat, and then you may have to veer away here and there based on the patient response. So those are the two things that I want to really stress as it relates to remote patient monitoring. So this is a sample remote patient monitoring workflow. One, identifying the eligible patient. Who's the right patient for this? When asking yourself the question about who's the right patient, we can't be selfish, y'all. We can't only think about the patient who their insurance is going to pay us the top dollar if we provide remote patient monitoring to them. We also cannot make assumptions. That is also a misconception. It is a misconception that only a certain age group or certain demographic is going to buy into remote patient monitoring and be able to do it. So thinking about the eligible patient, then enroll them and obtain consent, deploy the device, and there may be different ways to do this. You may have your vendor may ship out the device. You may use a bring your own device situation where they can use their smartphones and download the software. You may have a place where they pick up their devices. Right now, we use a lot of bring your own device, but we do reserve the right to ship a kit to a patient should they not have their own device. Then we monitor the incoming physiologic data, escalate the abnormal value. So this is why that protocol is so important, and that workflow, because, okay, you deployed your blood pressure cuffs or whatever it is you're doing, you deployed your blood pressure cuffs, you're getting your readings, they're coming back to somebody, now what? Now, what are we going to do with them? So you have to have that escalation path clearly defined, and then document and bill appropriately. And this is just a sample staffing model. This is not necessarily what we do here, but I will talk a little bit about how, I guess, some considerations when thinking about your staffing model. You always need your supervising provider. That can be a physician, NP, PA, whoever is serving as the primary provider for this patient. How I identify, or how I define this person is, this is the person who is going to be telling you what to do for this patient. So let's say they have consistently high blood pressures, and they've been on a beta blocker, and we've tried everything. They're doing what they're supposed to do, and a medication change is necessary, or an additional referral is necessary. Who will you be calling, or who will you be messaging to get the order that you need? Then you have your monitoring team, the RN monitoring team. This says about 1 to every 75 to 100 patients. I will say it depends on what you are doing for those patients. And also it depends on whether or not those nurses are having to do lots of administrative tasks. We also suggest an LPN or a medical assistant for first-line dashboard review. What that means is just what it would mean, in traditional practice. We know LPNs and MAs cannot assess, but they can carry out things, and they can report. They can report to the RN. So you can have an LPN or a medical assistant looking at the dashboard daily, and then they escalate to the RN. And then the RPM coordinator and device logistics support. So these are more administrative type tasks. These are the people that when the referrals come in, they're going to look, make sure that they meet all the criteria before they send it forward to the intake nurse or whoever it does intake for you. And then billing and compliance specialists. I'm sure that your heads are spinning. Trust me, even though we do this all day, every day, our heads spin as well when it comes to what the rules are, as far as remote patient monitoring and billing. So it's always good to have someone on your team who is looking at that all the time, and who can come back and say to you, sometimes they're not paying for this anymore. Sometimes, a few times, we have experienced, hey, y'all, we are missing billing for a service, using a billing code that we could be using because we're already doing the service. So one thing I want you to take away from this, so don't take this slide and go back and say, as Tearsanee said, one RN should be able to manage 75 to 100 patients. My goal for us is for one RN to be able to manage 200 patients. But the things to consider with that we're still working on is, how do we take away some of the administrative tasks that our nurses are performing so that they can provide patient care? And so that is something that we're still working on. So I just want to say that if you started and you realize that that's a problem for you, that's an issue that everybody has. So here is an example of remote patient monitoring in practice. This is a rural health clinic, managing uncontrolled hypertension and diabetes. In the rural health clinic or the rural clinics, you're probably not going to have a whole lot of staff. If there's anybody there working, those are your essential people. Those are the people that you have to have. So this is how this could work. The RN could monitor the dashboard daily. If you do have a medical assistant, they can perform first review. So they both have access to it. The medical assistant is probably going to be in that system more throughout the day than the RN, but they are escalating to the RN, and the RN has ultimate responsibility. The nurse practitioner handles the clinical escalation. So this is the person that's going to be writing the orders. And the goal for this is to improve their blood pressure control, or whether it's their glucose controls, and prevent fewer urgent visits. What you're trying to reduce here is not the visits to the clinic, but you're trying to keep them out of the ER and keep them out of the hospital. So here's another example of the things that remote patient monitoring can do or help with. One is, this is how it could work. The patient has been in the hospital for an inpatient stay, CHF, COPD, hypertension, diabetes. We identify who those patients are prior to discharge. This can actually be done, when I was in nursing school, they taught us discharge planning begins on admission. When that patient steps foot in that hospital, you're already thinking about what will they need when they are discharged. There is no reason this can't be done with remote patient monitoring. We know who they are. They're identified prior to discharge. They they're working with their transition RN and hospitalists for oversight. The goals of this are to keep them out of the hospital, of course, for at least 30 days, because we know that hospitals experience penalties when the patient bounces back within that 30-day monitoring period. But what it also does is it gives that patient the extra support and education that they need. Many ER visits are unnecessary. I worked in the ER for years, and I will stand by this, that many of the people who are in the ER who don't need to be there are there because they had a question. They had a question. They needed someone to answer their question. And guess what? The ER is open. So with this, I call the nurses partners in care. That patient would not rely on the ER to answer their question. They would rely on their RPM nurse to help answer their questions. Also, the RPM nurse is teaching them. So they're teaching them things like a blood glucose of 350. I don't care if it was normally 150. 350 is not grounds for an ER visit. Let's do these things first before you go to the ER. But we hope that we can schedule you to see your primary care provider. So the goal is to reduce readmissions and protect the value-based revenue. That's the goal for the organization. The goal for the patient is for them to feel empowered and have the tools that they need to better manage their chronic disease. I'm not going to spend a whole lot of time on this because we will spend a lot of time on it somewhere else in the boot camp. But I did want to share that there are codes for most of the things that occur during the remote patient monitoring program. Now, our remote patient program is fortunate enough to have a pharmacist. If you see here, there are no pharmacy specific codes here. But there's a code for the initial setup and patient education, the device supply and monthly transmission of the data, the first 20 minutes of clinical monitoring. There's a code for an additional 20 minutes. So what if you're on the phone with them longer than that? And then you, of course, also have to confirm the payer policies. It varies from payer to payer. Something else that's important to mention is that each payer defines chronic disease differently. So just because I think hypertension is a chronic illness, they may not. So that's something that you need to really look into too as you are planning for remote patient monitoring. Does anyone have any pressing questions about what I've presented so far? I don't think so. All right. All right, so the next section, we will talk a little bit about chronic care management. So chronic care management is non-face-to-face care coordination for Medicare patients. So this is specific to Medicare. It requires 2 or more chronic conditions. This is a monthly time-based service, no devices needed, and it is a strong fit for primary care settings. Can anyone guess why it is a strong fit for primary care settings? If one person can say it or can put it in the chat.
Repeat the question, please, Tearsanee.
Yes, the question is, why would you think that chronic care management is a strong fit for a primary care clinic?
Continuity of care, for one thing.
Absolutely.
Better outcomes.
Yeah. Continuity care, it would be my top answer. And it would be my top answer because in primary care clinics, they know who their patients are. They actually know them. And are kind of taking ownership, for the care of those patients. The next thing I would say is that it doesn't require a device. So nobody has to buy anything. You don't have to try to keep up with anything. You're already answering questions. When these patients are calling the clinic and they need, another medication refill, or a medication made them sick, or, they got something going on that's impeding their ability to be able to follow their treatment plan, you're getting these calls. The difference that I see right off the bat is this is now me as a provider or my clinic being proactive and checking in on these patients. So it's what we're doing already. But yes, those are two very good answers for that. So with CCM, we also have to obtain patient consent, develop a comprehensive care plan. So this is not, flying by the seat of your pants caring for these patients. There has to be a plan or goals established, and this is including the patient. Provide monthly outreach. It has to be at least 20 minutes, but it can be longer. You have to document that time, your cumulative time, and then submit monthly billing. Those are all things that are very doable in the primary care setting. The staffing model looks very similar to remote patient monitoring, right? Except there is no device. Supervising provider, physician, or NP, the RN care manager. This is the person that's going to be coordinating that the patient's needs. LPN or care coordinator support. Optional for a social worker or to have behavioral health integration, documentation, and billing support. So here's how this could work. This is an image of how this could work. You could have several primary care clinics. You've got 300 plus patients enrolled in CCM. You've got your RN care manager plus LPN support. Your LPN could be the person making the calls. Now they would have to escalate to the RN if there are any problems, but that helps you with your workforce management and leaves your RN to do things that require that level of licensure. They could focus on medication adherence and care coordination. These are were you able to pick up your prescription? Are you taking it as prescribed? Are you having any problems with your medications? Do you have trouble getting to the clinic, for your appointments? Do you have any other needs? And then acting on those things, not just asking the questions, but then doing something after that. And this creates recurring revenue and improves quality metrics overall. So you're taking full responsibility for that patient's care. And here are the reimbursement codes for this. You will get all of this, so you don't have to take notes. CCM, the first 20 minutes per month. If you talk to them more or longer than that, you can bill for the additional 20 minutes. Complex CCM, and there are some definitions for what has to occur for this to qualify as a complex CCM. There's a code for the first 60 minutes, and then a code for additional 30 minutes. And of course, as always, when using these codes, there are some very specific documentation guidelines to support the use of those codes. All right, so that was a simple one. Now, we are not currently doing a lot of the APCM, but we wanted to make sure that we shared information that we have on this model. It's very promising model, I think, and I look at it like CCM on steroids. You know, the big CCM model. But this is a CMS model supporting comprehensive primary care management. So you focus on panel level and risk stratified care. So you take all these patients you have and you stratify them by their risk. You put them in buckets by risk and support them using a team. So this is, did you get your appointment? Let me see what I can do to help you get your appointment. Did you make it to your appointment? Do you have any transportation issues? Let me make sure we get you to that. This is closed loop referrals. So I've sent you to the cardiologist. Did you make it to the cardiologist? What happened at the cardiologist? What else do we need to do? Kind of thing. So this is designed for organizations with population health maturity. So they've got to already be doing a pretty good job, you know, of the things that they're doing, that they know this is my population of patients. This works. And when I think about this, the type of organizations that fit well with this to me is those that like the elderly support, you know, those programs. I think PACE is one of those types of programs. I didn't want to call out a name, but it's the only way I know. Oak Street, you know, they only care for people of a certain age, and their patients are usually the same people coming back over and over again. This is a good model for them to use. So you'd have your primary care physician or MP. I see a pattern here. You got your primary provider. You've got an RN care manager, RM of some type. You can integrate behavioral health. You need a population health or data analyst, and then a digital health coordinator. So it's like case management, but with a heavy digital component. And so this is comparing CCM and APCM. They all kind of do the same thing. They just do it in different ways. So I want to compare first the features. Is it time-based? CCM is time-based. APCM is less rigid. Devices are required. Devices are not required for either of these two. CCM does not have a device component. APCM could have a device component. Panel level approach, CCM is limited. And then APCM has a strong panel level support. And then risk tiering. CCM, minimal risk tiering. You're calling your patients, you've got your group of patients, and you're going through and you're pretty much asking them all the same things. APCM stratifies them so that you know that this is my low risk group over here. I'm not having to do much for them. Here's my kind of mid-level risk patient, and then here are my high risk patients. And it's built into the system, depending on what criteria you put in there. So you definitely, this is highly analytical, the APCM model, because you are managing many more patients. So this could be 10,000, or so patients. The goal here is to meet those value-based metrics. If those metrics say that every patient should have a behavioral health screening every 3 months, this is going to help you identify those patients who have not had a behavioral health screening every 3 months, and then get you to them so you can do those screens. And here are the codes for those. And we'll share a more detailed information that actually has the expected reimbursement amounts for each of these codes for you to use in your organization. So payment varies by patient complexity tier. And then, of course, we have to verify the CMS updates annually. So disclaimer now, whatever we share with you might be obsolete next year, might be obsolete in a few months, but we can share with you the latest information that we have. So here's another side-by-side comparison. And yes, I know that it is repetitive, but y'all know in learning, you have to see the same thing a few times or hear it a few times, to get it. But the RPM is best for high-risk physiological monitoring, logic monitor. We all have those patients in primary care that we know that they've been in the hospital several times. We know that several times a year they're going to be in the hospital, or that they use the ER as primary care when we're not open. So those are those patients that would be great for RPM. CCM is for your Medicare population. You're giving them some extra support. You're checking in with them so that they're not out there getting worse and you don't know anything about it. APCM, this is the more advanced model. It's going to require much more interaction, much more of a heavy lift. So this is not the one that a new primary care clinic with only 2 staff members, should be pursuing. But you can mix them up. You can approach them in different ways. So for those of you that are on the call that are considering starting any of these programs, you may start at different places, at different phases. Some start with CCM fresh, just to see, I got somebody that can call patients and check in with them and do all of this. Some start with RPM and CCM. Some mix their CCM and their RPM programs together, kind of overlap them. And we have done that here as well. But this is a good roadmap to scaling telehealth care. You don't really have to get buy-in necessarily, for CCM, because you shouldn't have to spend any money to do CCM if you have the team already. So you start with CCM and you build your care management workflows. And you get that going, and you get comfortable with talking with the patients, and your staff gets comfortable with talking to the patients, right? And then you can add, out of that CCM group, you can add RPM for your most high risk. So these are your patients who are going to be in the hospital a lot, or who are coming, whatever you try to teach them in clinic, they're not grasping it. They need that extra support from the nurse. Then you could integrate hybrid workflows where you're doing a little bit of both, for the same population. And the goal could be to advance toward APCM maturity, but you may not reach that, and that may be okay. You may reach the goals that you need to reach for each of your patients without going to the APCM model, but it is there. But this is just a visual showing you how you could scale to that point. There was something else I want to say. I don't know. It'll come back at some point. All right. So organizational readiness. With the thumbs up, those who are members of the cohort, do you think that your organization is ready for any of these 3? I see a bunch of thumbs up. If you say no, it's okay. That's why we're here. Is it Tana?
Yes.
Is that how you say it, Tana? It's okay
Tana, yep.
to say, it's okay to say no.
We are not.
Yep, it's okay to say no, because guess what? That's what these discussions are for. And the in-person setting, we'll really dig even further into that to see how can we support you, in getting ready, or at least helping you identify exactly why you're not, or what needs to be there. So this is a safe space where it's good to say there is no way we can do this, or we're not ready.
Right now.
Yeah, exactly, or whatever is happening. That's why we're here. So these are questions we do have to ask ourselves. One of the constants that we saw in our staffing thing was, right, the provider. You have to have a provider, whether it's a physician, NP, PA, whoever it is, they have to be bought in. That's the other piece, is they have to be bought in. They have to be engaged, because many providers are accustomed to patients coming to them. I'm going to show up for work today, and I'm going to see the people that come into the clinic, and that's all I want. That's all I want to do. All of these require that provider to be willing to respond, to needs outside of those regular clinic visits. So this may mean that, they have a certain time of the day that they address the needs that have come, been brought forth by the CCM calls. It may be the same. They have a certain time of day, for that. It may be that they're coming out of a room with one patient walking down the hall and somebody stops them and says, I did this, and this is what they need, and they get their operations that way. They have to be okay with that. The other thing was the RN. Do I even have an RN? I know some NP run clinics may not, they may be the only RN, in that clinic. They may have LPNs and medical assistants. That provider has to be willing. I'm going to be the RN and I'm going to be, the provider for this. What is our payer mix? So if you don't have many Medicare patients, CCM is not going to yield much for you because it's a Medicare program, right? Are we in value-based contracts? Now, if y'all are in value-based contracts, like real value-based contracts, I'm impressed, because that is where RPM and CCM, I will say it is motivating. That's an external motivator, right? Because that they're looking to see if I'm going to take care of my patients in an exceptional way. And the outcomes are going to tell the story. For some, that's pressure, but it's a good external motivator. Do we have analytic support? How do you know what you're doing? I know we have everything in our EHRs, but is there someone pulling that data out that can show you, like a report card of, are we doing a good job in caring for our patients? We all like to believe we are, but the numbers don't lie. And can we support device logistics? If we cannot support device logistics, or we're not working with a vendor who can handle that, maybe we are not ready, for any of the programs that require a device. So that's for us to think about. And then there's a little matrix here that you can look at some other time, that just kind of, when you're thinking about my organization, if it requires a lot of tech, maybe I'm not ready for RPM, but I can do CCM. If it requires a lot of staff or heavy on the staff side, APCM is probably not for our organization. And so we talked about too, the populations or the groups of people that we are serving. So common pitfalls, I mentioned this right at the beginning. Technology first instead of a workflow first approach. Greg Hall is on our call. I know his eyes probably butt because he thought I was going to ask him to do something. But Greg is our IT director, and this is something that he and I both preach, and is that when you want to start something with telehealth, we need to know what you're trying to accomplish first. And then he can talk to you about some possible technology solutions to help with that. Oftentimes you may already have what you need, but we have definitely found that we're spending money in places where we don't need to spend money sometimes, because we're looking for the coolest technology instead of the coolest technology to do what we need to do clinically. So that's one of the big things. Understaffing our RN monitoring teams. You got 400 or 500 patients, and you say, I'm only going to have one RN. Well, you don't know how sick your patients are going to be and what those RNs are going to have to do. Poor patient selection criteria. We're just throwing everybody on the program. Well, that's a lot of work, knowing that all of them will not be good candidates for this, but just not picking the right people. Weak, I keep saying that, weak PCP handoff processes. What is your process for notifying the primary care provider? A tip, it has to work within their current daily workflows. It can't be like in a different spot. So if you're working in an EHR, if they are accustomed to getting messages from people in their inboxes, maybe that's where those notifications need to go. If they are accustomed to working from a work queue in their EHR, maybe that's where those notifications, need to go. But it needs to be in line with what they currently do every day. And then also lack of executive sponsorship. So if you're in a larger organization, You definitely need buy-in. Anytime you are doing something with tech, I'm not gonna say anytime, but most often when you are doing something that is tech related or related to telehealth, you're gonna have to spend some money up front. And it may take you a while to make that money back and then get to a place where you are operating, at least breaking even. Because it all depends on your goals. So I will say that too. These are not things that you initially start off with the mindset that we're going to make a lot of money off of these. It takes some time to get to that point where you can. But making sure you have that executive level sponsorship is important. So key takeaways: RPM, physiologic monitoring. That's what it was. That's what I was going to say. It just came back to me. With our RPM program, we do the physiologic monitoring, but one of the things that we feel is kind of non-negotiable is education. We don't want to be, sitting in the back, not interacting with the patients, not giving the patients something while we're also monitoring them, monitoring their blood pressure, weights, and glucoses. So we are teaching them along the way. So our diabetes patients are learning how to manage their diabetes. Our hypertensive patients are learning how to manage hypertension, how to change their diets, how to incorporate reasonable exercise into their lives, because we don't want it to be a crutch. And we want the patients to see it as being beneficial and have long-standing results. That was the part I was going to say, because this is heavy on physiologic monitoring, but it's also an opportunity to teach the patients. Then CCM is structured care coordination. Remember, it doesn't require a device. So almost anybody could do some of those things, any organization. APCM is a population health strategy. It's heavy on the analytics, because you have to know who these patients are and also to be able to track whether you are taking good care of those patients. Staffing and workflow determine your success, and hybrid models where you're mixing up two or even all three of these represent the future. So are there any questions on this? And I see Sean was able to join us. Today, we weren't really sure whether he was going to be able to make it because he was having some difficulty with technology. You think that? But no, his internet was down. But he was able to join us. So we'll take a moment for questions and any thoughts about your specific organizations, any initial thoughts. No, there are no wrong answers. This is a safe space. So share anything or what. How about this? If I can get 2 or 3 of y'all to just say what you think those that said they were ready, what do you feel like next steps for your organization might be?
So we've had CCM for a little bit, and we've tried to kind of potentially dabble into RPM, but I think that's our next step.
Okay. And where are you in that process? Mara, is that right?
Yes. So we've kind of talked about it a little bit, but we haven't really acted on that yet. So
okay.
Just in
beginning stages. Okay. Anyone else? What do you think your next steps are? Or is your brain full? Oh, Sandy?
So I'm stuck. I'm just going to be real honest with you. I've been the executive director for over the years, and we dabbled past tense with CCM. That slide you put up, do you have any case managers, or I would say extra case managers? And I don't have that. And I've tried to figure out, the concept of buy or make,
Yes.
Do you use a company or do you do it yourself? And I just stop and start with CCM or PCOCM, the other one, and now the
PCM.
CPM or whatever that's called. And then from a remote patient monitoring, I have a very good success with our PACE program, but not in the FQHC. So I need like a jump start. I know my problem isn't everybody else's problem, but I can't get out of my own way with this. And that's why I was invigorated to be involved in the boot camp. Thank you.
Yeah, so that was great. I mean, I appreciate you sharing it. That's exactly why we're here. That's exactly why we're here, to help people just think through, what are their needs? What have you done that didn't work? Really digging down into the why didn't it work? What were our goals? That's the other piece, is sometimes it's not that you can't do something. It may be we need to scale back our goals for that, program. Like, are we trying to do CCM for just the general population of Medicare patients, or are there certain ones, that we really want to do this for? And I will say this, and I'm not sure what your situation is in your organization. It requires a behavioral change for the clinicians, the people. So when you said like extra case managers and things like that, is sometimes your staff can be accustomed to, this is what I do, this is my job, this is all I do, and this is the way I do it. And so sometimes it does feel like it's extra and it's an option, so it's kind of, you have to go in like, this is what we're going to do. This is not an option. And then you scale your team, based on that. So sometimes that's the issue. I'm not sure. Sometimes you just really don't have enough people for what is happening. And that goes back to what I was saying about RPM and kind of where we are, today, is when we started off, we couldn't have an intake person and somebody to verify eligibility and all of this and an RN. Our RNs did all of that. But as we grow the program, we need to give that to somebody else, and let the RNs be nurses. Let them function at the top, of their licenses. So the questions that we're asking ourselves now, or I'm asking team members, is what do you do every day that somebody else could do? That doesn't mean we have it right now, but how much of your time every day is dedicated to something, but there is somebody else available that they could do that. Somebody without a license, that they could do that. So that's one of the exercises, that we recommend for that. So, all right. Anyone else want to share?